Okay, let's just get right into it. If you have ever found yourself staring at one of those colorful dermatome maps, you know the ones with all the stripes showing where nerves go, and you're trying to make your actual real-life leg pain fit into those perfect little lines, well, this is for you. Today, we are going to trade all of that confusion for a really clear, practical way to figure out what your symptoms actually mean and what to do about it. And this just nails it, doesn't it? It gets right to that feeling of frustration. The pain is 100% real, but the map in front of you feels like it's for a different person. You end up trying to describe your own leg like a weather forecast, right? Looks like it's mostly achy in the calf with scattered tingling around the big toe. It's exhausting. And your confusion? It's totally valid.
So this is the big question, isn't it? If those neat textbook charts aren't the answer, then what is? We're about to make a huge shift here, moving away from trying to find the perfect label to building a practical plan. All right, first step, the confusing pain map. Before we can build something better, we've got to understand why the old system, those maps, so often let us down. Really getting why it's a problem is the first step to actually finding a solution. You see, here's the thing. Those maps are drawn with these clean, Sharpie-like borders. But our bodies? They just don't work like that. In reality, your nerve roots have a ton of overlap. They kind of borrow territory from each other. So a signal from one grumpy nerve can easily feel like it's spilling over into its neighbor's zone. And that's why your pain probably doesn't fit neatly into just one stripe. And this is another huge piece of the puzzle. Your sciatic nerve isn't out there performing a solo. You've got other things like a cranky hip joint or a tight glute muscle that can scream down your leg and do a really, really good impression of sciatica. I mean, even sitting on a thick wallet can do it. It just goes to show other body parts can totally cosplay as nerve pain.
Okay, so we've established the map is, well, kind of useless for our purposes. So that brings us to section 2, a better triage system. This is where we stop chasing the perfect diagnosis and instead build a system that helps us decide what action we need to take. It's all about moving from label to action. And here it is. This is the new framework. Think of it like a pyramid. At the bottom, you have pain. It's the loudest signal, right? It's what gets your attention. It's your first clue. A step above that, you have sensation. Things like numbness or tingling. These are often a bit more reliable, a bit more consistent than pain. But at the very top, the most important signal of all is function. What can your muscles actually do, or what can't they do? That tells you about urgency. So this is the big mental shift we need to make. We are all programmed to ask, which nerve is it? Because getting a name for something feels like we have some control. But you know what a good clinician is really asking? They're asking, is the nerve getting weaker? They're looking at the trend, because that is what really determines what needs to happen next. Okay, time for section 3. Let's put our 3-signal system to work. We're going to look at the 3 most common nerve roots that cause sciatica, L4, L5, and S1, and see how we can use our new pain, sensation, and function framework to spot their classic patterns. Let's start with L4. An irritated L4 nerve usually sends pain down the front of your thigh, often wrapping around to the inner part of your knee and shin. For sensation, you might feel a patch of numbness right on that inner lower leg. But here's the kicker, function. The big clue for L4 is knee control. If you feel like your leg might just give out or buckle when you're going downstairs, that's a huge sign pointing towards the L4 nerve. Now, L5 tells a totally different story. The pain route for this one is classically down the side or outer part of the leg, right across the top of the foot, and often landing in the big toe. A classic sensation clue, numbness in that little web of skin between your big toe and your second toe. And the function test here is all about lifting things up. Can you pull your foot up? And more specifically, can you lift your big toe? Weakness here is a big deal, and it's sometimes called foot drop. In fact, let's make this super practical. Right now, if you can do it safely, just sit down and try it. Try to lift the big toe on your painful leg all by itself. Now, try the other side. Is there a big difference? Does one feel way weaker or harder to move? That simple little comparison is a powerful way to check in on your L5 function. And finally, S1. This is your classic pain in the butt pathway. It usually starts in the glute, runs down the back of the hamstring and calf, and ends up on the outer edge or even the bottom of your foot. And the critical function test here? It's your push-off power. Think about it. The power you use to go up on your tiptoes. If you struggle to do a single leg calf raise or feel weak when you push off to take a step, S1 is a likely suspect. So we've learned how to look for patterns. Now we get to what is, without a doubt, the most important part of this whole thing. Section 4, your action plan. This is where we turn that knowledge into real-world safety, by figuring out exactly when it's okay to monitor things and when you absolutely need to make a call.
Okay, let's be crystal clear. These are the non-negotiable drop everything and get help now signs. If you have any new problems with controlling your bowel or bladder, any numbness in your groin or saddle area, or any weakness in your legs that is getting noticeably worse fast, this is a medical emergency. You do not wait, you seek immediate medical care.
All right, so for everything else, this is your guide. It's generally okay to be in watchful care mode if your pain kind of comes and goes, but your strength feels stable. The numbness isn't spreading, you can still get around okay. On the other hand, you need to call your doctor, like today, if you notice new or worsening weakness. If that foot dop thing is new and now you're tripping over your own feet, or if the pain is just becoming unbearable, make the call. Remember, worsening weakness always trumps pain when it comes to urgency. So what's the best thing you can do starting right now? It's not to guess more. It's not to stare at that confusing map again. The single most powerful thing you can do is start a really simple symptom log for the next 3 days. I promise, this turns the chaos of your symptoms into clear, useful data that's gold for you and any doctor you talk to.
And look how simple this can be. A couple times a day, just make a quick note. Number 1, where's the pain traveling today? Number 2, what's going on with any numbness or tingling? And number 3, the most important one, test one function, just one. Do your big toe lifts or try a single leg calf raise, and just note how it feels compared to your good side. That's it. Simple.
Because in the end, we just have to let go of this idea of finding a perfect label on a map. That's a myth. Real control, real understanding comes from seeing the trend. Is my function stable? Is it getting a little better? Or is it getting worse? So I'll leave you with this question. What is your 3-day log telling you about what your next safest step should be?